कैसे लग रहे थे?
तो वहां से जाओ जो अपन ने बनाया पोर्टल। Sir, you are mute. Vaibhav sir, you are mute. Please unmute yourself.
To copy the sound, press any key. Charges ₹30. Just when you dial,
Am I audible to everyone?
Yes.
I request Dr. Poonam Modia to kindly present the bouquet to Dr. Arun Khadikar sir. Thank you, sir. Lectures throughout the year from various disciplines of dentistry. The program is brainchild of our President Sir, Dr. Vaibhav Karimore. So I would request Sir to please address the audience and tell us more about it. Dr. Karimore. Hello. Very good afternoon, respected Dr. Abhay Datarkar sir, Dean of this prestigious institution, Government Dental College and Hospital, Nagpur. Dr. Arun Khadikar sir, Head of the Department of Prosthodontics, Government Dental College and Hospital, Nagpur. My colleague, my elder sister, Dr. Poonam Modia, Honorary Secretary, Indian Dental Association, Nagpur branch. And I can see in the audience, Dr. Pandnaik sir, Dr. Anshul Mahajan is the Vice President, ID Nagpur branch, Treasurer, Dr. Vivek Thombre, and the past President, Dr. Krishna Rahul. I welcome you all for this magnanimous program, that is International Continuing Dental Education series organized by Indian Dental Association, Nagpur branch. This was a thought of Dr. Sandeep Fuladi. Basically, he was very eager to have an international CDE somewhere, but the past 2 years were very pathetic for us. And finally, we are somehow meeting online. Now we are going hybrid, and hopefully If the conditions are going very positive, with less positivity rate, will definitely go the international CDE. One announcement I want to make today on this forum that Indian Dental Association Nagpur branch is completely digital now. Now you can have each and everything regarding Nagpur IDA and dentistry, what is happening in and around dentistry in India. Is available now at idnagpur.org. I request all the members who are online here, please give this message to all your colleagues that we are online now, and this is very hassle-free process. You can have your membership renewals, you can have all the registration for all the sports, cultural, as well as all the educational events at idnagpur.org. I extend all my best wishes to this CDE series. Today, I'm thankful to Dr. Lee, right from Malaysia. She is delivering today on Crown and Bridges. This is the privilege of our moderators to introduce her and the topic. So I'm not taking much of your time. I give all my best wishes to this international series of continuing dental education. And this is what I welcome you all. This is how I welcome you all for this CDE program. Thank you very much.
Thank you, sir, for the kind words. Before we start the program, I would like to call upon our Honorable Secretary, Dr. Poonam Hodia, to please propose the vote of thanks.
Hello everyone. Someone has very rightly said, good things come to people who wait, but the better things come to those who go out and get them. Good afternoon, one and all. On behalf of IDA Nagpur branch, I, Dr. Poonam Huria, Secretary IDA Nagpur branch, would like to thank Professor Dr. Liang Lin, Dean School of Dentistry, IMU Malaysia, for accepting to deliver her expertise in the first online CDE, that is International Series of Webinars on Mastering the Art of Crown and Bridges. We appreciate you making time in your busy schedule, ma'am, to speak to our members. Thank you again for your time. Ma'am, we are very much confident that your years of research, your depth of understanding of user interface, and your ability to present the subject in an interesting way will surely make one of the most memorable lectures in our organization's history. Thanks to our moderator, Dr. Abhay Datarkar, sir, Dean Government Dental College and Hospital, for accepting our invite and spare his valuable time for the event. We are also thankful to Dr. Abhay Datarkar, sir, for allowing IDA Nagpur to use the auditorium of GDC Nagpur for the conduction of events, and I would like to thank GDC team for the same, for their enthusiastic help for the event. A heartfelt thank you to Dr. Arun Kalekar, sir, Professor Head, Department of Prosthodontics, GDC, for accepting our invite, for being the moderator and sparing his valuable time. Thank you, sir. I also wish to express my gratitude to President, Dynamic President, Dr. Abhay Karamure, for his making this webinar series happen. According to him, no things can stop him. If we can't go offline, we'll go online. But hats off to our president, sir. My thanks to Dr. Mitul Mishra, CDE coordinator, for coordinating this event very well and for helping us organizing this event. I would also like to thank Dr. Vivek Thombe, Dr. Sachin Khatri, Dr. Padnaik sir for their presence throughout. I would like to thank Wiz Software for being a part of this event and helping us with the technical part. A big thank you to enthusiastic attendees who have participated in large number. IDA Nagpur is very thankful to them. And last but not the least, thanks to my IDA Nagpur branch team who have always been supportive every day. Ladies and gentlemen, once again, thank you for being with us this afternoon. I assure you that this is going to be a great knowledge session. Take up very good care of yourselves. Stay tuned. Thank you so much.
Thank you, ma'am, for the appreciating words. I now request all the dignitaries to kindly take their seats in the audience. The moderators will hold back. And in this webinar series today, we are presenting first lecture on topic Mastering the Art of Crowns and Bridges. The webinar will be presented by Dr. Liang Ling. Just to brief on the topic, crowns and bridges are considered as the part of bread and butter of general practice and are routinely recommended for patients requiring indirect restorations to protect the weakened tooth structure and replacing missing teeth for aesthetics and functions. Advances in material sciences, digital technology, and adhesives have revolutionized and simplified the treatment procedures. Dental practitioners must adopt this rapidly changing landscape and evaluate these newer advancements that have the potential to improve and enhance the desired treatment outcomes in both the interim and final phase of treatment outcome. This lecture will focus on evidence-based knowledge, contemporary techniques in various stages of crowns and bridge work, and giving emphasis on adhesive dentistry and minimal invasive dentistry. Now I'll give before taking much of the time, I'll give the platform to moderators of today's program, Dr. Abhay Datarkar sir. Sir, please take the mic and the stage is yours.
Thank you, Dr. Mithun. We are going to start the CDE, the first of its kind CDE, that is international CDE organized by Indian Dental Association, NAGPUR branch, and I have been given a task to introduce the speaker for today. The speaker for today is a well-known faculty in the field of dentistry. And I must say, Government Dental College and Hospital, Nagpur is having a special relation with the Dean of IMU. Now you will ask me how, because one of our alumni who is working as in the Department of Prosthodontics, Patil, and his better half is also there in the Department of Orthodontics. So we welcome you, Indian Dental Association Nagpur branch and Government Dental College and Hospital Nagpur, Dr. Lee. And to introduce Dr. Lee, she is the Dean of School of Dentistry at IMU, International Medical University, which is Kuala Lumpur in Malaysia, and has previously served as an academic staff in the University of Malaya for 10 years. So she is having a vast experience in the field of prosthetic dentistry. She received her postgraduate training in prosthodontics from Eastman Dental Institute and the University of Manchester, and PhD split site program. She is actively involved in continuing professional programs to share her knowledge and experiences with fellow colleagues. She has conducted many workshops and lectures widely at various regional and international conferences. Her areas of the interest include fixed prosthodontics, aesthetic, direct composite restorations, adhesive, and cardiology. Basically, this is the need of the day. Whatever the areas of the interest she is having in this specialty. She has also been actively involved in research and has won numerous awards at the international and national level. She has traveled a lot for giving the lecture forums nationally and internationally. She is responsible to drive the postgraduate programs at the International Medical University, and she is also a founding president of Malaysian Association for Prosthodontics. So it is our proud privilege to welcome a professor for this particular very prestigious CDE, what we call as International CDE. I congratulate all the organizers of Indian Dental Association for having you on board for the Indian Dental Association of Nagpur. And I request you to start your presentation. The stage is yours. Thank you so much.
Excuse me, just a small announcement. Before we start the program, just a little housekeeping before we start. If you have any questions, please don't interrupt in between. Just type your questions in the control panel, in the question box in the control panel. We'll take it up at the end of the session. Then we can start your lecture.
Okay, thank you very much for the kind invitation and also the kind introduction. Yes, I am really grateful that we have Dr. Praveen Kumar Patil to serve us in International Medical University. He has been an amazing staff. He is currently the program director for our postgraduate diploma in prosthodontics. So he has done really, really well. And also we are looking forward to having more collaborations from the Indian Dental College, from NAGPUR. So we look forward to collaboration in dental education and also in research as well as other program like CDE, you know, to benefit our patients. We learn together. So without further ado, can I share my screen?
Ma'am, the rights has been given. You can share your screen.
Yes. Can you confirm that? Are you able to see my screen?
Yes, ma'am, it's visible.
Okay. So is it in a screen presentation mode now?
Yes, ma'am, screen presentation mode is perfect, ma'am.
All right. Okay. Wonderful. Thank you so much. Once again, it is indeed my pleasure to be able to share my knowledge and experience with all of you. I like the introduction where you say that crowns and bridges is the bread and butter of general dental practice. So I totally agree. And this lecture aims to enhance your knowledge and skill so that we bring the best to our patients. As what we would aim for, we provide evidence-based practice for our patients. So for this lecture, I will cover comprehensively from treatment planning right up to provisional restorations, secondary impressions, and also cementation, because each and every one of these steps are very important to make sure that the outcome is what we want. Okay, I can't move the screen. Okay. All right, so before we start, it is very important to carefully evaluate all the abutments or the teeth that we are going to restore. First, utmost is the periodontal support, whether the tooth is mobile or not, whether there's a lot of bone loss, and then the periapical consideration as well, whether there is any periapical lesions, any periapical radiolucency. So always, before we start, we must take a radiograph to evaluate the periapical status. This is really important because we don't want to have incidents when after we put in the crowns or bridges, then we found that the tooth has become non-vital. There's actually periapical lesions that we have missed. So we are liable for the mistreatment in that sense. And occlusion. Occlusion is the key to all success in prosthodontics. Prior to starting the prosthodontic work, we must evaluate the occlusion. What sort of occlusion does the patient have, and what sort of occlusion scheme are we going to provide? Are we going to conform to the existing occlusion, or are we going to increase the vertical dimension or not? And then we also look at the abutment status as well if we are going to restore it with crowns and bridges. So I will touch mainly for this part on resin bonded bridges, cantilever bridge, fixed bridge in terms of treatment planning, and then I also illustrates all this with cases that I have treated. So resin bonded bridge is one thing that we always shy away from, because in general practice, it's always have this misconception that resin bonded bridge doesn't last long. I do agree that resin bonded bridge may not last as long as fixed bridge. But on the other hand, it is of very, very minimally invasive. You know, you do not have to trim away enamel, you don't have to trim away dentin. So fixed bridge is of a biological cost because you are removing dentin and enamel. For resin bonded bridges, if you have sound abutment, that is almost like a virgin tooth. You really don't want to sacrifice all these things. So for patients who cannot afford implant and have a missing tooth, resin bonded bridge is a very, very good option. If we execute it well, you can see that from a systematic review that was done 2017 out of 29 published papers on resin bonded bridge, and comprises altogether in these 29 papers, there are 2,300 resin bonded bridge. And we can see survival is 91% for 5 years and 83% for 10 years. I would say this is quite a fair success rate because it is of so minimally invasive. If you have a resin bonded bridge that fall off, you can always re-cement it. It's of very, very minimum biological consequences. So we have found that from this systematic review, the most common failure is debonding, which is really minor, and minor chipping. Again, it's really minor as well. Unlike if you have a fixed bridge, it could lead to the tooth become non-vital, it could lead to secondary caries, and eventually you could have a fracture of the abutment tooth, which sometimes you may not be able to salvage it. So with this frame in mind, that we should have a paradigm shift. For patients that cannot afford to have implant to replace a single tooth, resin bonded bridge is a good consideration. But we need to have good case selection to ensure good success outcome. So patient factor is very important. Abutment selection as well. Nowadays, we do single wing rather than two winged. And what sort of occlusal features do you put in to ensure better retention and resistance form? With current adhesive dentistry, improvement in the resin cements that we have, we are seeing more and more resin bonded bridge being put in and have good success rate. So eventually it also boils down to the technical competencies that we have. So for conventional design, this is the design that we used to do with two wings. Nowadays, we do not do two wings like this as well, because we know that both the adjacent teeth has differential movement because they are of different axial direction. So when you eat and chew, they move in different direction. That will stress on the cement loop, which may eventually lead to failure. So nowadays, we tend to do single wing like this. If you need to replace two teeth, then you actually separate them into two separate ridges with one wing on each side. And we also need to make sure that there is enough thickness. If we are doing resin bonded bridge, the metal that we use would be a base metal. And base metal, although it's strong, you still need to have certain thickness. And 0.7 is what has been shown by research that is required to avoid flexion. If you have very thin metal, they will flex and that will cause de-cementing as well. And also routinely now for my resin bonded bridge, I will prepare a receipt, just like our denture for cingulum rest or for occlusal, mesial or distal rest. So in this case, normally you cantilever to the front, replacing the missing tooth at the front. So let's say you have a missing 1/5, you can use 1/6 as the abutment with the wing on 1/6, replacing that. So you will have a rest seat prepared on 1/6. For posterior abutment, sometimes you have the bulbosity. You can shave off a little bit of the bulbosity to remove the undercut. Just like when we do denture, you survey the undercut area. So if you remove the bulbosity, then you can enable to have bigger coverage for your wing. And then we also do wrap around retainers as much as possible so that we increase the retention, increase the surface area for cementation. So this is about using a molar replacing a premolar. So it has a receipt preparation plus a bit of occlusal as well. because this is on the upper tooth, aesthetic is not critical. On the palatal cast, you can never see from outside. So because there is no occlusion on the palatal cast in this case, so I can actually cover the palatal cast to increase the surface area for cementation and also increase the retention and resistance form as well. If need be, if you have a short crown height, you can do a little bit of electrocautery to increase the crown height as well. So this is another case where I learned from my own mistake. So this patient has 2 resin bonded bridges which I put in. One is to replace 1, 2, one is to replace 2, 3. However, the one on 2, 3 debonded after 3 years. The one replacing 1, 2 is still there after for 5 years. So what is the reason? If you see the first bridge that we put in, we can easily understand. It's very small coverage area. You can see the little wing. There is not enough area for bonding. And also this was done like 7, 8 years ago. Cement also is a bit inferior quality compared to what we have, the better adhesion and better resin luting cement. So we changed the design to having a palatal cast coverage, and it has stayed on for about 3 years now. So what is the issue with the using metal as a wing? The graying of the incisor edge. If you have a thin incisor, you have an incisor edges that is translucent. So even though you can say you use the opaque cement to mask the grayish appearance of the metal, it is still affecting the aesthetic. So nowadays with the CAD/CAM technology, we are moving into using zirconia resin bonded bridge. So zirconia, you treat it like your zirconia crown. You just sandblast the surface and then cement like what you cement a metal resin bonded bridges using a proper resin luting cement, etching and bonding. Okay, I will touch on the cementation at a later part of my presentation. So this is a case that I have done. This is a CAD/CAM mill zirconia resin bonded bridge. So we sandblast the pontic and you can see the design. I covered the palatal cast as well to increase the surface for bonding and also increase retention and resistance form as well. So this is another case, lower anterior. Patient has congenitally missing 3-1 and 4-1. 3-2 and 4-2 has moved closer, so the gap is only 1 tooth gap. So she end up with lower 3 incisors. But if we execute it well, people actually won't be able to count, oh, this patient has 3 incisors or 4 incisors. So because this is lower, the metal can be visible when patients smile and talk. So we have discussed with the patient and proposed to have a zirconia CAD/CAM mill bridge as well. So this has been cemented again for about 4-5 years and it is still in place and in function. So what I'm trying to say now is if you select your case properly and you execute technically sound, then it should stay. Because now adhesion, we have better understanding of adhesion and also better cement for us to use as well. So from resin bonded bridge, the next one that I would like to talk about is cantilever bridge. So let's say you have a clinical situation when one tooth requires a crown and adjacent to it has a missing edentular space, and then the other abutment is totally sound. Of course, we don't want to cut the totally sound tooth to provide a fixed bridge, right? So cantilever bridge is a very, very good option. However, there are a few criteria that we must observe to ensure the success outcome of this cantilever bridge. So let's see what is the criteria prerequisites for successful cantilever bridge. First, the abutment tooth must have good periodontal support. And for anterior cantilever, we prefer to use canine as abutment to replace lateral as opposed to using the central incisor. The reason is because the central incisor tend to have conical root and shorter compared to canine. But in a scenario that, let's say you have a central incisor that require a crown, then we can't help it. We will use the central incisor to cantilever the lateral incisor. However, for occlusion, like what I mentioned, occlusion is very important to ensure the success of our prosthesis. When you do excursive checking, when patient do anterior excursion, you should not have any excursive force on the pontic itself. So this is very, very important. So the excursive forces should be on the pontic, should be on the abutment and not the pontic. All right. And for posterior cantilever, we normally cantilever anteriorly, meaning to say you use molar to cantilever a premolar or a 1-5 to cantilever a 1-4. We do not use 1-4 to cantilever 1-5. So I hope this is clear. The reason is because all our teeth has a tendency to mesial drift. If you use the anterior tooth to cantilever posterior, if the tooth moves slightly anteriorly, then you will have a gap between the pontic and the other tooth behind it. All right. So stress distribution as well, like I said, the masticatory force, you should have very light contact in ICP on the pontic and should not have lateral or protrusive loading on the pontic at all. All right, so let's have a look at what literature tells us. What is the success rate for cantilever bridge? So Peterson has done a very comprehensive systematic review on various design of fixed partial denture. And this particular data is on cantilever bridge. So they have cantilever bridge that has been followed up for at least 5 years in 13 studies. And they use a Poisson's regression method to estimate for 10 years survival rate. So survival rate has been estimated 10 years, this to be 81.8, success rate to be 83. Then you will ask me, what is the difference between success rate and survival rate? This we need to be very careful when we read literature. Survival rate, meaning to say the prosthesis is in the mouth, but the condition regardless, it need not be the same as when the day you cement it. It can have a fracture ceramic, the tooth can be mobile, and so on and so forth. But for survival rate, the prosthesis needs to be exactly the same like what it was cemented from day one. So it should not have fractured in ceramic, the tooth should be firm as it is. There should not be any secondary caries around the tooth. So that is the success rate. So that's why you see success rate is always slightly lower when reporting. So that's why a lot of people prefer in a way to report survival rate, because they don't tell you that there could be secondary caries, there could be periodontal involvement, there could be fracture ceramic, and so on and so forth. But as long as the particular prosthesis is in the mouth, it's considered survive. Okay, and then what are the complications from this review? The complications that they found is mainly biological, loss of pulp vitality. We all know it has been reported for crowns and bridges, you can get up to about 25% of the teeth that receive crowns and bridges become non-vital over a period of 10 years. And secondary caries is one of the biological complication, and fracture of abutment actually is quite low at 2.9. You would imagine if you think that, oh, cantilever bridge, you are actually loading more on your abutment, right? Then you can see that this review doesn't really reflect it like that. Okay, so let's have a look at some clinical cases. This is a tooth that has been root treated and treatment plan to receive a crown. So this is a tooth 7, and the patients 2.4 and 2.5 are totally sound. And 2.6 has been extracted long time ago, and 2.7 has slightly drifted in front. So the 2.6 space is actually slightly smaller, as you can see. So that's why we actually plan to do a cantilever bridge to replace the 6. So this is being cemented. So because I don't want to touch the 5. The 5 is totally sound. I don't want to cut the sound to issue a fixed bridge. And I also, the patient also don't want to put in an implant as well, because the space is quite small. It's very tight for an implant. We all know to place implant that space needs to be at least 7 to 8 millimeter to get enough bone at both adjacent area to avoid bone loss. So in this case, then cantilever bridge is one of the better option. So another case, root treated, you can see the access cavity is still having a temporary cement, and the patient has lost 2.5 in this case. 2.4 is totally sound and rotated. So again, I don't want to cut this 4 in this case because it's rotated, higher risk of jeopardizing the pulpal health even. So we remove the crown, and then, you know, there is some secondary caries underneath the crown. So on hindsight, this case is actually referred to me by an endodontist after completion of the endo. So this is a lesson for us to learn. In future, if you see that there is a case with secondary caries, it is preferred that we remove the crown first to evaluate the extent of the secondary caries first prior to carrying out the endo treatment. So let's say in this case, after removing the crown, we found that the secondary caries is so extensive, it has gone down all the way to alveolar bone area, very subgingival. What are we going to do? You know, so that's why it's very important when we see that there is a defective margin and there is secondary caries, we should remove the crown to evaluate prior to carrying out the RCT. So restorability of the tooth needs to be done first. So in this case, same thing. So we restore it with a cantilever bridge. As you can also see, I deliberately keep the margin high. The reason is because this tooth has recession of the gingiva and there is furcation involvement in this area. I don't want to go into that furcation area. That's why I keep the gingival margin supragingival. Patient has very low smile line. When she smiles, you can't really see the crown margin. So we explain to the patient and patient is acceptable to it. So this is how we do the occlusal checking. Sorry. So this is using shim stop. This is on the abutment itself. It holds the shim stop. You can see that, you can hear the sound. This is on the pontic. It's very light contact. It's just nice going through. Shim stop is very thin. So this is the best paper to evaluate the the occlusion, the contact. So this is another clinical case that I would like to share with you. Patient is 29-year-old and she has come in to request for fixed prosthesis option. Currently, she's wearing a little spoon denture replacing one. And she also doesn't like her smile as well. We can see that why she doesn't like her smile. She's relatively young and pretty. And you can also see it's a relatively neglected mouth with retained root here, large caries on tooth 6. This tooth also got, you can see here, there is a sinus here, PA lesion with sinus. So the whole treatment plan, because patient is having torus as well, so she has a bit of problem tolerating her denture. So she wants something fixed. So this midline is also not coincide. So first line of treatment, we explained to her to correct her midline and also lower crowding. Obviously, orthodontic correction would be the best because she also have cross bite here as well on the two and lower incisor. But she doesn't want to have ortho, so we try to use fixed prosthodontics to improve on her aesthetics. So prior to that evaluation, like what I have mentioned, periapical evaluation, the PA radiograph has shown that both 1-2 and 2-2 has PA lesions. So we need to carry out RCT first prior to that. But we would also want to see what is the end results that we can achieve to improve her aesthetics. So with the diagnostic wax up, you can either do conventional diagnostic wax up like this, or you can also do digital wax up, 3D print out the provisional, then you can issue the provisional for the patient to see what would be the end result. So either way, conventional or digital planning, it's fine, as long as you know how to do the whole workflow. So after root canal treatment, we prepared the tooth. So what is planned is 1-2 and 2-1 will have 3-unit fixed bridge, and then 2-2 has 1 single crown. So some may ask me, oh, since you are prepping 2-1 and 2-2, why not you link the 2-1 and 2-2 together? Then you get better retention. No, this is not the principle of fixed bridge, because if you link these two abutments together, then 2-1 become a fulcrum. You know, it's like a seesaw. 1-2 and 2-2 become like a seesaw. So one of these two who has the weaker link will fill. Once the cement loop fill, then secondary caries may seep in. That's one thing. If you link the two abutment 2-1 and 2-2 together, then patient will have issue in cleaning because you can't floss through in between these two teeth. So the principle of fixed prosthodontics will tell us, do not double abut. That's what we call double abutment. Just leave them single, fix, 1-2, 2-2-1, and 2-2 is a single crown on its own. So take impression, light body and heavy body on a special tray to ensure that we capture all the margins. And then this is the provisional. In her mouth, you can see that we managed to correct the cross bite. And then this is the fixed prosthesis, the final one. So no linking the two together. So this is patient. You can see the changes when she first come. This is before treatment, interim, provisional prosthesis, and this is her final treatment. All right, this is a profile after issuing of her bridge. So this is another patient. So this patient come in, he has two main concerns. One is he find that lately he can't really chew properly which we can understand because he has lost one posterior teeth here. Here also there's a retained root and there's a large caries on 2-6, which he is having a bit of pain. The anterior teeth has fractured, so he doesn't like his mouth. So what we did is, as routine investigation, you must do radiograph. So the 2-6 doesn't have any periapical lesion and pulpal response is normal. The canine has retained root, which needs to be extracted. The anterior 2-1 also needs to be extracted as well because this is deemed unrestorable. So this is the planning. So we need to replace 1-6, and then we need to replace the missing 2-5 and 2-3, and also 2-1 as well. So what we plan is fixed bridge with cantilever canine. Because the 4 and the 6 has severe recession of the gingiva, so we decided that we need to keep the gingiva margin supragingiva, because if you go down further, the tooth become more conical. So your prep will become even more aggressive. So in this case, we discussed with the patient. The patient has very low smile line, it's not visible. So it's not advisable to bring the crown margin any further down. So in this case, you can see the margin is nicely flush, very good fitting. Patient have no issue in keeping that area clean at all. And then this is where we use resin bonded bridge to replace the missing anterior teeth, because 1-1 and 2-2 both are totally sound abutment. We don't want to touch them. And patient also cannot afford to have implants, so we resort to resin bonded bridge like this. And the posterior, this is the earlier one that you have seen. Again, missing 1-6, we use 1-7 to replace the missing 1-6. So this is total rehabilitation for the patient. You see 1-5 and 1-7 are totally sound. Again, we don't want to cut sound teeth. Patient cannot afford implant, doesn't want to wear removable prosthesis. So this is how we use adhesive dentistry and resin bonded bridge to rehabilitate the patient. So in the end, we get a happy patient that can smile and eat well. So let's talk a little bit about all ceramic restoration, since all ceramic restorations has been in use for quite some time. We need to understand the background of the various types of ceramic currently available to us. We need to know how to treat them to maximize the bonding of the restorations to the tooth. So successful application depends on your material selection, your tooth preparation, your manufacturing technique, also cementation and bonding procedure as well. So this is very important that we understand all ceramic. We cannot send it to the lab and tell the lab, oh, I want all ceramic restorations. Then you need to know which type of ceramic they give you so that you know how to treat them accordingly to maximize the bonding. Currently, the most common one in the market is glass ceramic or zirconia, what we call etchable ceramic or non-etchable ceramic. So the glass ceramic, the lithium disilicate, lithium silicate, lucite reinforced feldspathic fall into glass ceramic, the etchable category. The zirconia, alumina fall into the non-etchable category. We also may want to know a little bit more on the current zirconia. Zinc zirconia, from its start until now, it has made a lot of progress as well. The earlier version of zirconia is the 3Y zirconia because it has a 3 millimole of yttrium particles, which make it very opaque but strong. That's why previously we mainly use zirconia for posterior teeth. But nowadays with newer version, we have more translucent zirconia, which is the 5Y. So it has a higher percentage of the yttrium, make it a bit more translucent and aesthetics. So now we can use the 5Y zirconia for anterior as well, provided that your technician knows how to stain them. We also need to know whether it's monolithic or layering. Monolithic means the whole crown has been milled in total and the technician achieved the aesthetic just purely by staining and shading the crown. But in some situation, if you need more translucency, then the technician may just cut back a bit and layer it with more translucent ceramic. In this case, then the total strength of the ceramic is actually depending on the weaker link, which is the layering ceramic. So sometimes you do see detachment of the layering as well. All right, so we need to know when you order your all ceramic crowns and bridges, you need to specify what do you want. You want a etchable glass or you want a non-etchable, you want a monolithic or you want a layering to achieve the aesthetics that you would like to have. So I would just like to share with you how to achieve aesthetic outcome for all ceramic crown. This is one of my earlier case. I think this case must be like about 10 years old now. How I learned through this experience. Okay, so this boy, he's a young boy, I think in the early 20s, had a motor vehicle accident and fractured his central incisor 2-1. So root treated, we put in a post, and then this is a composite build up for that particular tooth. Then we prep for crown. So this is shade taking, and then crown prep. And this is the provisional in place. And this is the crown that come back. You see what happened is because this is a root treated tooth. As we all know, when it had accident, the tooth become non-vital, the blood vessel burst, and it has made the core color quite dark. So this is my earlier Emax crown. As we all know, Emax crown is relatively translucent. So what happened in this case is the grayish color of the core has shown through. So then discussing with the technician, then I come to learn that there is a natural dye shade guide as well, besides the guide that we have for our crowns and bridges. You know, let's say we want A3 or we want A2, but we need to also know the stump color. What is the core color of the tooth? You may have a natural dye shade 5, natural dye shade 9, you know. If you are, there is a non-vital tooth, probably the core, the stump color could be quite dark. So for Ivoclar Viva then, they have come up with a color wheel. So you need to take your end color that you want, for example, A3, and then you also need to let the technician know what stump color do you have after crown prep. So it could be ND5, ND6, then there is a color wheel for the technician to know which block to use to achieve the end results of A3 for you. So we did that and it come back better results this time. All right, so next, after treatment plan, we go down to execution of our crowns and bridges procedures. So we need to do provisionals after our crown prep. We need to do secondary impressions after our crown prep. So which one do we do first? I would say we do provisional restoration first before secondary. So now my workflow in my office is such that after I prepare my crown, When I'm happy with my crown prep ready, and then I will start to do my provisional restorations. When I'm happy with the amount that I reduce and the margin, because from the provisional restorations, I can evaluate all my gingival margin, whether it's clear or not. So if I'm happy with that, then I put it aside. Then I go and put my retraction cord, insert my retraction cord. So we all know insertion of retraction cord, you need to have the cord in for at least 5 minutes to effectively retract the gingiva. So after retraction cord, we need to leave it for 5 minutes. So I come back to polish my provisionals because I know that the margin is good, the reduction is adequate. So I polish my provisional restorations. Then after I polish my restoration, the 5 minutes would have been up. So I proceed to secondary impression taking, remove the retraction cord and then take my secondary impression. When I finish my secondary impression, my provisional is ready, nicely polished. Then I cement my crown. So there's no time waste at all. So why do I say we use provisional crown as diagnostic first? Because it gives us a lot of information. For example, if we are changing the smile like earlier, the girl, so then we can use our provisionals from our diagnostic backup to evaluate the aesthetic outcome. And then we also can evaluate the adequacy of our crown preparation and our gingival margin, whether your gingival margin is clear or not. If your provisional can record your gingival margin, similarly with your secondary impression, and the technician can see the gingival margin as well. So currently there are main two category of provisional crown and bridge material. One is the PMMA, which come in liquid monomer and the powder form, or the BGMA base, which is composite base, either integrity or protem for, so whichever you like. The downside of PMMA is there is a lot of heat being produced when this material set. And also the polymerization shrinkage is much higher. The polymerization shrinkage for PMMA is around 15 to 20%. That's why sometimes you see that, oh, how come my margin doesn't fit that well? Earlier on, the margin was better, but when it's fully set, then you can see that your margin has shrunk. The BGMA one has less polymerization shrinkage. So they tend to have better margin fitting. And also the polishability for BGMA is much better. So they are more aesthetics. Okay, so this case, what happened is, like I mentioned to you, that do not link all the crowns together, because these 5 crowns has been linked all together. And patients complain after 2 years of issuing these crowns is he cannot clean it properly and he has foul smell in the mouth because the food get all stuck in the interproximal area. And also the gingival area for the crowns are very bulky. We can understand why. When I remove all the crowns, the margin of the crowns are not clear. So the technician has overbuilt the crown. So that is a plaque entrapment area. So that's why patients have foul smell in the mouth, being not able to clean interdentally, and also a bulky gingival margin. So the gingiva are all very swollen and bleed when he brushes. So we remove all the crowns and then place and refine the margins first to ensure that there is adequate margins, and then we place provisionals, let it heal, then we proceed further. So another case, you can see that there is, this tooth is still vital, but there is crack line. When we remove the caries, it has a very large, deep caries. So you can see a crack line here and a crack line in the lingual. So we propose to the patient, we need to have a full coverage crown to avoid this tooth cracking. So the provisional is good to let you see that you have adequate reduction. because for this case, I am proposing to do a zirconia crown. For zirconia crown, I only need 1 millimeter of reduction. So you can see my provisional here, my reduction is 1 millimeter. So this caliper is a very useful tool to have in the clinic. So in my clinic, I always measure my provisional and see whether I have enough room for my technician to produce the crowns and bridges for me. So that's the reason why you take the provisional first, then only the secondary impression. If you found that your provisional is very thin in certain area, there's not enough reduction, then you can always go back and do more reduction before you take the secondary impressions. Okay, so this is a astringent paste to retract the gingiva before I proceed for secondary impression. So another case, failed crown, there's like almost 7 millimeter of probing that. So we, after remove the crown, we discuss with the patient, this tooth is not salvageable. So we extract it and then we put in a provisional bridge for him. The advantage of having a provisional bridge like this is so that we can scalp the gingiva area. You can see that I put in this provisional 3-unit bridge for about a month or so to wait for the socket to heal, and you can see that it's nicely scalped. This is a provisional in place. This provisional in place was left there for about 4 weeks or so before I proceed to secondary impression. Again, we also use the caliper to measure the thickness of the crown prep. And then shade taking as usual, and this is the final prosthesis. So in fact, recently I just reviewed this patient. This bridge has been there for 6 years plus and it is still intact. So now we proceed to secondary impressions. So the most important thing is you need to have good gingival health before you take impression. So our gingival margin can be supragingival, equigingival, or subgingival. So now my routine is for anterior teeth, I either do equigingival or only 0.5 subgingival. All my posterior teeth are all supragingival, unless the crown height is really, really short. Because posterior aesthetic is not important, supragingival, you can enable the patients to keep it nice and clean to avoid secondary caries setting in. Then we use retraction cord. Retraction cord in Malaysia, I'm not sure about in India. In Malaysia, they are generally non-impregnated. So we need to soak it with either aluminum chloride or sulfate, ferric sulfate, some form of vasoconstrictor to control bleeding. So some of this astringent product, you need to be careful because, for example, ferric sulfate actually interfere with polymerization of polyether impression material. So if you use the ferric sulfate as an astringent, then you need to make sure you rinse it off properly before you take impression. So single cord or double cord, I must say that nowadays I don't use double cord technique at all because I don't want to over retract and then I run in the problem of recession of the gingiva later. All right, so please use a special instrument. These are special cord packer. They are thinner than our plastic instruments so that it will not traumatize your gingiva. So you go bit by bit to insert the retraction cord. So this is normally how I ended up with. So it may look a little bit messy, but to leave out, after going one round, to leave out a little bit of the end part is very useful, especially if you are doing multiple crowns. It enables you to pick up nicely. If you embed all in the gingiva, it's very difficult to find them. And then if you accidentally prick the gingiva, it starts to bleed. It will affect your accuracy of your impression. So this is what I normally do to enable me to just pick up one by one very nicely without traumatizing the gingiva. If you have a little bit deeper subgingival margin prep, you can actually use electrocautery to expose the margin, but needs to be careful with the medical issue of the patient, and also do not touch any metallic restoration at all. All right, special tray versus stock tray. If I only do 1 or 2 crowns, I can use metal tray. Otherwise, I normally use if I'm doing like 4 or 5 crowns, to ensure the equal thickness of the impression material, to ensure accuracy of the impression material, then I will resort to special tray. If I use special tray, then you must make sure that you use tray adhesive depending on the type of impression material you use as well. For VPS, the vinyl polysiloxane material is different adhesive compared to your polyether. So please make sure you use the correct tray adhesive for the impression material that you are using. So you can either use monophase, for example, the same material on the crown prep and same material on the tray, or you use light body and heavy body. My personal preference is light body on the crown prep and regular body on the special tray, like this. All right, so ultimately we need to look at the flow property, the hydrophilicity, the test strength of the material to ensure that we have a good quality impression for the technician to produce the prosthesis for us. So polyether and vinyl polysiloxane is the 2 current popular polymer elastomer impression material that we have. So polyether has been there for a long time. It has good working time. It's stable. The only downside is a bit more expensive, and also it doesn't have that. It has a unpleasant smell and taste. Some patient doesn't like it, but the newer version actually has a minty taste to it. And we need to understand that polyether actually absorb a bit of moisture from the atmosphere. So if, like in Malaysia, because we have almost 90% of humidity, I believe in India as well, humidity is high. So if you take impression using polyether, before you send to the lab, preferably you use an airtight container to keep the impression. Of course, you need to disinfect it and dry it properly, then keep it in the airtight container, because we don't want to have the impression material absorb moisture, because they can absorb moisture and then it affect the accuracy. And vinyl polysiloxane nowadays have very good accuracy. In fact, it's comparable to polyether. A lot of surfactant has been added to make it less hydrophobic, because the initial problem with vinyl polysiloxane is that it's very hydrophobic. So if you have a lot of fluid, saliva around your crown prep, it may affect the accuracy. But now with the surfactant, this problem has been overcome. So next, you receive the prosthesis back from the lab. So we go on to cementation and bonding. I specifically choose the word bonding because, like earlier on, I mentioned if you have a glass ceramic, the etchable, we actually bond it to the tooth. Once you bond, then the whole tooth restoration complex strength goes up. In fact, the EMAX, the lithium silicate or lithium disilicate, it only have the fracture strength around 300 to 400 megapascal. But once you bond them on, the strength of the whole tooth restorations complex can go up to about 800 megapascal, which is strong to withstand your occlusal bite force. Our posterior occlusal bite force is normally around 500 megapascal. So currently we have RMGIC, the resin modified glass ionomer, resin luting cement, a proper resin luting cement where you need to etch and apply dentine bonding agent on your tooth. That one you can use it to cement your veneer, cement your resin bonded bridge. The other category is the self-adhesive, when you do not need to etch and apply bonding to your tooth, because this category of self-adhesive resin cement, it has a formula that when the catalyst and base is mixed, the pH goes down to around 2.8. So it sort of self-etch the dentine a little bit, then to provide some adhesion to it. But the bond strength of this class of cement is not as strong as the proper resin luting cement. So it's not advisable to use this to cement your resin bonded bridge or veneers. Normally, veneers have a special cement which is light cure, because you want to have more time to work with the veneer. This few class, they are dual cure. When it's dual cure, once you mix it, they start to stack. So you have very little time to adjust the veneer and all that. So normally to cement veneer, we have a special veneer cement that is light cure. All right, another note to take is for all ceramic crowns, especially the glass ceramic, do not use RMGIC, because RMGIC expands slightly when they set. So if they expand slightly, they have the potential to crack the all ceramic crown. It has been reported in the literature that all ceramic crowns that is cemented with RMGIC has seen some micro cracks in them. And we all know micro cracks, if in the mouth function for some time, then there will be crack propagations and eventually failure of the crowns. All right, so for all ceramic crown, if it's an etchable glass ceramic, then you need to prepare the crown and also prepare the tooth as well to maximize the bonding. Okay, for the crown, you need to etch it with hydrofluoric acid. So as you can see in this picture, it's a porcelain etch. So it's not phosphoric acid, it's hydrofluoric acid, normally 8 to 10% of HF. You etch it for 30 seconds, then you rinse it off, you apply silane. So that is very important. You need to apply silane coupling agent, because silane coupling agent is a bipolar molecule. One end of it will bond to your dentine bonding agent, and the other end will bond to the silica within the ceramic. That's why you etch it with hydrofluoric acid to expose the silica, so that the silane coupling agent can latch on the silica in the glassy face of the ceramic. And it has been shown in research, if the silane has 10 MDP, the bond strength increases. All right, so for the tooth, you etch it, you do etching on the enamel first for the first 5 seconds, then only go on to the dentine. Don't over etch the dentine, because the fibrils of the dentine will collapse if you over etch it. So you etch the enamel for 5 seconds, then only you go and etch your dentine for another 8 to 10 seconds, so totally about 15 seconds or so, and then rinse it off thoroughly, apply dentine bonding agent. And do not cure the dentine bonding agent, because if you cure it, if you have pooling of the dentine bonding agent, your crown may not sit fully. So you apply dentine bonding agent, and then you apply cement on your crown, and you cement it together, then only you cure it. Okay, so this is a luting of a bridge. So this is what I would normally do. I just twist a floss around at the connector area so that I can hold the bridge. And then once I cure it, then I can open up the floss I didn't tie the floss, I just twist it around. I open up the floss and remove the excess at the interproximal area under the pontic and the connector. Because under the connector and the pontic, there's always a tricky area to remove the excess cement. All right, so this is the final restoration. So similarly for other cases. So, okay, that is my presentation. Thank you so much for listening in on a Saturday afternoon. Thank you. Oh. I'm happy to take any questions if there is any questions. Oh, what?
So there are questions.
Okay, all
Ma'am,
right.
just a second. Chairperson will take the hold for asking the questions.
Okay.
Hello, am I audible, Professor?
Yes, yes. I can hear you clearly.
Yeah. Thank you so much for such a wonderful, elaborative presentation. And we really appreciate your time and commitment for this particular lecture today.
Mm-hmm.
I will hand over the mic to the Professor of Prosthodontics, Dr. Arun Parikar, sir. I think he will brief regarding the topic and then we'll take few questions and answers.
Okay, sure.
Thank you. Thank you, madam.
I can't really hear you well. There's a lot of echo.
President, sir, you are mute actually. We are not audible.
Okay. Okay. So I will start again. Crown and Bridge constitutes the integral part of prosthetic rehabilitation, given the high incidence of cases encountered in clinical practice. I would like to take this opportunity to thank Professor Liang for having simplified this topic and emphasized more on the modern crown and bridge prosthodontics. The presentation truly covered all horizons possible and has surely enlightened all us about the core principles of fixed partial dentures. Thank you, madam. Thank you very much for your presentation. And there are a few
My
questions.
pleasure.
I will put one by one. Thank you.
Hello there.
The first question, how can we use the functional curve as a retainer in case of replacing premolar using palatal cusp of molar in resin bonded prosthesis? This is the first.
Okay, you can use the palatal cusp of the premolar to replace. If the palatal cusp is in function, then you need to reduce it. You need to make space for the metal. So you need to reduce about 0.7, 0.8 millimeter to give space for your metal. Am I clear?
Yes, ma'am. Will you please repeat? There is a little problem here. Please repeat your answer, ma'am.
Yeah, You can use the palatal cast as the pontic, as a replacement for your resin bonded bridge. You just need to ensure that you have reduced, you need to prep the palatal cast. You need to give about 0.7, 0.8 of space at the palatal cast for the metal. And then the patient will bite on the metal.
Thank you, madam. The second question, how can we give a pontic on a canine using resin bonded retainer?
So if I am not mistaken, you mean the canine is missing, right? Then you can use the tooth 1-4 or 2-4 to as an abutment. Like the case that I show, I use a premolar. Then your canine should not have a canine guidance. So the guidance should be on your premolar and molar instead, on lateral excursion. As I mentioned, the pontic should not take any lateral excursive force.
Next question is, madam,
Yeah.
what occlusal scheme is favorable for resin bonded prosthesis in the anterior region?
Okay, a very nice question. So the occlusal scheme is such that you have only light contact on the pontic in ICP. In anterior guidance, there is no contact on your pontic. The anterior guidance should be on your abutment and other natural teeth. So that would be the occlusal scheme for this kind of case in the anterior region.
The next question, what astringent do you prefer to gingival extraction?
I personally prefer the aluminum chloride. The reason is the ferric sulfate. I use polyether to take impression sometimes. So the ferric sulfate may interfere with the polymerization, and also ferric sulfate tend to have little black mark on the tooth, so it doesn't look that nice. So my preference is aluminum chloride.
Okay, thank you, madam. The last question, enlighten us about the importance of biology.
Okay, biological width. Can I share my screen so that I can explain with a slide? Can you give me the right to share my screen, please?
Yes, we'll give. Himanshu, please give the right to share the screen.
I can't share my screen.
You can share the screen, ma'am. You can share the screen.
Okay, all right. Can you see my slide now?
Yes.
Okay, so I have this. You see the biological width, research that has been done in 1961 and a research done in 1994. That is like almost 30 years apart. But the biological width remains the same. It's about 2 millimeter. So this is the biological width from the base of your periodontal pocket to the tip of your alveolar bone. So this is a constant. What I'm trying to say is in 1961 and 1994, the finding is the same, it's 2 millimeter. So what we don't want to do is if we encroach into here in the junctional epithelium, if we place our crown margin too low, then in order to maintain the biological width, then the tip of the alveolar bone will have to resolve. Correct. So that the junctional epithelium and the connective tissue can move apically. So you are causing the alveolar bone to resorb. So it's iatrogenic in a way. I hope I have made myself clear.
Ma'am, there are two more questions. What is your opinion regarding graphene-based crowns as an alternative to other tooth-colored restorative materials?
Graphene crown, to be honest, I don't use graphene crown, so I can't really comment on graphene crown. I think it's sort of like not really in production anymore. I don't know, in Malaysia we do not use graphene crown, so I'm so sorry, I got no experience in graphene crowns.
The next question, how does silenization improve bond strength in zirconia retailers?
Okay, silane doesn't really for zirconia crown, you can salinate it, but the outcome is not as significant as compared to your etchable ceramics, because you can't really etch zirconia, so you do not expose a lot of silica particles in that zirconia crown. You can put silane, but it's just that the advantage is not as great as what you see for etchable glass when you etch it and then you expose the silica in a glassy face material.
Okay, thank you, ma'am. Another question. What are your views on cervical margin elevation in case of deep proximal subgingival caries? And what material do you use?
Okay, I use composite. When the deep margin elevation concept came out years ago, they proposed to use GIC because the argument is GIC is less sensitive to moisture, because in a deeper part of the gingival margin, there will be gingival fluid, right? So the argument was GIC is less that sensitive, but the thing is GIC is very weak material. They will fracture under the occlusal loading. And also it's not really as insensitive to moisture control as what we thought it is. So nowadays, there is a paradigm shift. Most of the people would use a retraction cord in the area to make sure there's good moisture control, then use composite, etch and bond composite, which is a better material compared to GIC. So nowadays, I tend to use GIC if I have to do margin elevation.
Thank you, madam. Any questions from audience? You can ask now. Thank you very much, madam, for enlightening us and giving very nice answers.
Thank you.
All the questions are answered to my knowledge. I would like to thank Professor Lee for such a wonderful presentation today. Though this is not my specialty, but I could learn so many things from this particular topic today. And
my pleasure.
In your beginning, in your introductory remark, let us have some collaborations in the form of exchange.
Yeah, sure.
And patient care, so that it will be beneficial to all of us, your students as well as our students, and obviously IDA will be a major platform for us. And I hope to see you very soon physically in coming year. Thank you so much. Thank you.
Yes, I would like to extend invitation to all to come to Malaysia to visit us.
Our monitor, sir, for handling this webinar very well. Now I request our moderators to kindly present e-certificate to our today's speaker, Dr. Lynn ma'am.
This is a certificate.
Thank you very much. It's very kind of you.
Thank you so much, ma'am. Now I request our honorable secretary ma'am and president sir to present e-certificates to our moderators, Dr. Satarkar sir and Dr. Khadikar sir.
I request Dr. Suryakan to please come on stage. We want to give a certificate of appreciation for coordinating this program in the Department of Prosthodontics. So on behalf of
Thank you so much, everyone, for being part of this webinar. And thank you so much, ma'am, for conducting this webinar on behalf of IDA NAGPUR branch. We
My
look
pleasure.
forward to,
Thank you.
some more nice and similar kind of webinar series coming months. Thank you so much, everybody. The e-certificate for all the participants will be available on their IDA branch account. They can download it from there. Thank you so much. We'll end this session with the national anthem. So I request everyone to please stand on their seats and we'll have the national anthem. It will be played now.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाये तव जय जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय जय।
Thank you so much. We'll leave now.
Thank you.
Nikita?